All right, good morning to everyone who's joined us. I'd like to welcome you to the We're All Wondering panel discussion. And I am CCB, Director of Audience Development here at One Workplace. And this is one in a series of conversations that we've been having about the human impact of COVID-19 on different industries and different vertical markets. Our One Workplace healthcare team collected this amazing group of panelists for us to have a conversation with. And I want to say, please feel free to send in your questions to our panel through the Q&A function at the bottom of your screen. And as we have time, we will certainly make sure that we address as many of those as we possibly can. Prior to COVID-19, the industry of telemedicine was at a tipping point, expanding far beyond interactions between care providers and patients into entirely new ways of delivering healthcare and practicing medicine. I saw some interesting facts that over 75% of hospitals already connect with their patients through telemedicine. Annual telehealth visits among commercially insured patients increased annually by 52% between 2005 and 2014, and then 261% increase between 2015 and 2017, according to the Journal of the American Medical Association. So you think that was 2017, where is the usage at this moment in time? So we've all been wondering about what the human impact might be from this rapid acceleration of telemedicine, and particularly as shelter in place and social distancing even further removes the human touch and replaces it with technology. So our panelists each have amazing backgrounds and very impressive credentials, and I would be loath to read them all off to you because we'd use the entire time. So to that end, we're going to give it back to our panelists and let them introduce themselves with an overview of their experience and their passion, especially as it relates to how can we make this experience be more human. So first, I'd like to invite Megan Zweig to join us.
Perfect. Thanks so much. Thanks so much for having me. It's great to be here with you all to talk about a really important topic, and one that I think about all the time in my role. I am the Chief Operating Officer at Rock Health. So we are San Francisco based, remote for now. We are an early stage venture fund in the digital health space. And then we also are an advisory services business. And in that capacity, we work with large healthcare organizations like health systems, health plans, pharmaceutical companies, as they figure out how to transform to be digital first companies. And I think, Caroline, you said it really well, that this transformation has been a long time coming. I think, we report out every year on things like what's the use of video visits, the use of wearables, remote monitoring. And we kind of, I think, reported last year, we're seeing this precipice, we're seeing this big push in the direction of being able to provide care at a distance. It's efficient, it's accessible, it scales the medical workforce that we have. It's what consumers want, but I mean, now we're kind of like off the cliff in terms of COVID really forcing us and mandating us to consider these tools in ways that providers and patients just haven't in the past. So really excited to be here. That really is what I'm passionate about, is kind of the scalable adoption of technology solutions in healthcare with the intent of, as we say at Rock Health, making healthcare massively better. And we've invested in a lot of these telemedicine, remote monitoring, digital therapeutic companies. So happy to share more on that as the conversation goes along. And just wanted to give a special shout out to Trevor, who I know works with you at One Workplace. He and I did an executive MBA program for the past year and a half. So we are kind of newly graduates from that program. So just wanted to share a little bit of that in terms of my kind of professional, personal background.
Thanks so much, Megan. Our next panelist is Anurag, who is, I almost want to say a polymath, but I'm going to let him explain what his interests and his experience are.
Thanks, Carolyn. That's jack of all, master of none.
No.
What a remarkable time for us to be having this conversation. This is once in a 100-year crisis, if you could call it that. That seems like an understatement. Under the shadows of that, a lot of things are changing, and this topic is really important, close to our hearts. I'm a faculty member with the School of Medicine, affiliated with the Center for Biodesign, which is a medical technology innovation program, and Center for Global Health, which is focused on bringing health interventions to underserved settings around the world. And from both of those lenses, both of those centers' perspective, this is a remarkable time because it really has had a global impact. I do have another role as a co-founder of a strategy consulting firm, OWP Medical, where we work extensively with health technology companies around the world, and they are seeing the impact as well. They've been at the center, along with hospitals and others, in how this has impacted them and what they are going to do to serve the patients better. So no better time to have this conversation than now. It's unfortunate, but maybe there's some good things will come out of it. I'm happy to share some of the stories and examples as we proceed.
And we are extremely interested in hearing what both you and Megan have to say. And as it relates to what we do at One Workplace as deliverers of effective spaces, places to serve people in their work environment, we work with many different design firms across the United States with all of our clients, our customers. And one of our colleagues in that endeavor is Donald Cremers with HOK. So I'd like Donald, introduce yourself relative to the conversation that we're having.
Great. Good morning, everyone. I'm Donald Cremers, and I'm a principal in the San Francisco studio of HOK. Many of you probably know HOK as an international design firm. And many of our studios have a healthcare practice. So we cover healthcare projects across the country, into Canada, Europe, and also Asia Pacific. I personally work on various types of healthcare projects, mostly on the West Coast, extending up to the Washington area, to the Utah area, but I also have the opportunity to work occasionally on projects in Asia. I'm working on a very large project right now with the Public Health Authority for Hong Kong, which is very interesting. And as Caroline said in her introduction, many of our clients who are healthcare providers have a vast array of telemedicine capabilities. And we're really curious to see how that will evolve now, as there's a bigger push to keep all of the patients and customers and members healthy. So that means that we interact with space in a different way. And then what kind of effect is that going to have as we circle back around and just see broader availability of healthcare available to all of these patients and members?
Great. So we've got lots covered here in experience and expertise. And I think the first question that everyone has been asking is, with this rapid acceleration by the COVID-19 situation and the sudden implementation of social distancing and shelter in place, many people have been removed from resources that they access on a regular basis. And so it highlights telemedicine and its value, and we wonder how do we square the value of the distant tool and the need for some kind of social connection. So that's the human impact. And I'd love to start with Megan on that one.
Yeah, an example comes to mind. So I guess I'll start with kind of something specific from one of our portfolio companies, because I think as you've nicely said, sometimes we think of there being a trade-off between technology and the human connection, but I'm going to kind of pressure test that assumption, and maybe these things aren't mutually exclusive. So one of our portfolio companies, they're called Mairal. They work in the substance use disorder space. So their intention is really to support patients who are recovering from an addiction, and they start managing them right at the point at which they've been discharged from an inpatient rehab facility or outpatient rehab facility. And they have a care manager who's assigned to them with the intention of preventing relapse and keeping in touch with that person. But it's really hard. There's one care manager, there's many patients. And so what Mairal does is they've built a digital platform to essentially create anonymous chat groups amongst discharged patients, because that community can actually be really important for social bonding, for sharing an experience with others that have gone through it. And what kind of the fancy Marigold algorithm does on top of that is it uses machine learning to understand the sentiment of those conversations. And so the care manager isn't kind of listening in to this entire conversation, but they are notified if and when something is happening in that chat that could be an indicator that this person is going to relapse or is at risk for another mental health issue or anything else. And so I would argue that kind of that seamless monitoring enables the care manager to intervene and be the person, be the human connection, even if it is probably over the phone or through a video visit, but it allows them to intervene at the appropriate moment so that they do have that human touch point. And so I do think that we still need to think, like, how do we humanize the experience of telemedicine? But I think technology and remote monitoring is incredibly powerful so that we can have that telemedicine touch point at the right time when the patient needs it and wants it.
So we had a pre-chat last week, and I was intrigued by some of the work that Anurag's doing at Stanford with some of your design students and employing design thinking. And it goes back to this human first, human concern. So could you speak a little bit about that for us?
Yeah, thanks for that, Carolyn. And I love the example that Megan provided. I do agree that technology and human touch are not mutually exclusive. But the challenge has been that a lot of work that has happened in healthcare, especially from information technology tools point of view, has been driven by engineers and I'm an engineer, so I can say this, by engineers who are great technologists, but haven't really thought about what our users, what our beneficiaries, what our patients really needed. EMR systems are a good example. Even though they were very powerful tools, they didn't really advance this patient-physician interaction in ways that it had the potential to. And part of the problem has been that this has not been user-centered design. Biodesign program that I'm part of actually focuses on unmet needs with the user at the center of it. And it's my belief that if we approach it that way, we approach from the unmet needs perspective, not just from the point of view of one stakeholder, but all key stakeholders that any solution is going to ultimately impact. I think we would have a better solution that's human in nature, that is easy to use, that actually results in outcomes that we want. And frankly, a number of women's health and other solutions that have come out that use technology, information technology, in recent years from biodesign have actually shown that. So I do feel that the onus is on us as designers, as developers of technology, to actually approach it that way. The other thing I would say, the reason the time is nigh, that the reason we got to be actually thinking about this and we have to use technology in an effective way is that there has been this trend over the history of healthcare. All the care used to be provided at home or near home in 30s, 40s, 50s. And as we start building big hospitals, we start moving a lot of care to hospitals. And, there is an increasing demand, especially in light of COVID-19, for example, to bring that care home. So I think the future of healthcare is going to be this blended approach for significant problems. The patients will have to come to the hospitals because they are absolutely needed for saving lives. But with certain kinds of things, there's no reason why we can't bring the same quality of care and same level of human interaction to homes using technology.
Okay, I'm going to say that if you ever want to jump in and respond to somebody else's comments, you are more than welcome to. But I have one more question that I want to ask of Donald first, and then we can start to have a scrum around this. So Donald, Anurag has just mentioned the place, whether it be home, whether it be the healthcare environment. And with all of the work that you're doing, we had a number of questions about, the size of major healthcare operations have grown We can look in San Francisco at UCSF and the massive hospitals, that have they're popping up on a regular basis. And we know that the time frame for developing those massive projects is extended. So what do you think, what are you seeing today, and what do you think the impact is going to be on the demand, moving forward?
Well, I think there's the potential for the idea of place to be much more dispersed. So we certainly talk about telehealth being in the home, but I think that it could also be dispersed into smaller facilities that are faster to build. Maybe they're modular, maybe they're actually mobile and they can move around through neighborhoods. Because what we're also seeing is that you have these huge facilities, and if there's some sort of outbreak, the facilities for the most part are almost empty. You have a certain number of patients and providers that are in the facilities, but the facilities are really on lockdown. So they're not the most efficient way of actually connecting with the patient and with the people who need those connections. And then to bring it back around to the whole premise of what this discussion is about, and trying to figure out what's the human point of telehealth, I think by having this disbursement where people could actually go to a place in their neighborhood to connect digitally to their care provider, I think that provides the opportunity for there still to be almost like a care manager or a care concierge that could be in any of these smaller facilities. So the person still feels like that they have a one-on-one personal connection. They have assistance navigating through this system, which might be difficult to do at home. The technology that's available in these places is probably much greater than people would have in their own home. So I think you're going to see things like that start to happen in terms of how we use space and build space.
Yeah, I actually completely agree with Donald, and I'm glad that he brought up, it doesn't have to be home, it can be facilities, smaller facilities in the neighborhoods. A great example is a lot of surgical procedures are moving from hospitals to ASCs, ambulatory surgical centers, and remote technologies, telehealth technologies could be super valuable. One of the example I'll give you is that of stroke, ischemic stroke. There's a remarkable treatment called mechanical thrombectomy that happens in these big hospitals where there are neurointerventionalists doing these treatments, but the stroke happens in the homes and communities and the neighborhoods, and those patients ultimately get moved using ambulances, paramedic vans to these facilities, and often time is critical in identifying whether somebody is a large vessel occlusion patient, somebody who's got a big stroke or not. I mean, telemedicine can actually be useful, not just in the buildings, but inside the vehicles as well. So as you think about, your work, Carolyn, in the future, I suspect it's not just designing and building facilities that are large, but also bringing healthcare to these smaller modular settings, as Donald said.
Right.
So thanks for that. I'm struck by the language that we're using, and there's telemedicine and there's telehealth, and then there's all sorts of the digital interventions that Megan, you addressed in talking about your portfolio. So I'd love us all to talk about the breadth of what those offerings are, because it also, that ties it back to the giving back to the human when we think about the extent to which digital health can be managed today.
Mm-hmm. Yeah, I can kind of tie that question in with the prior conversation, because I think we are starting to see a lot of creativity and how we can put these digital tools to work. I think we aren't at the precipice in terms of innovation in this space. And one thing that came to mind, Anurag and Donald, when you were speaking, is we work a lot with, can you hear me okay?
Yes.
Just wanted to do a check. Okay. We work, with CVS. We're on top of kind of how other retailers are positioning themselves to be really central to delivering care in neighborhoods. So when you think of the CVS health hubs or minute clinics, when you think about, Walgreens, Walmart, they all have a play in this space, and they're interested in, how do we scale the pharmacist? Like, how do we scale the healthcare talent that we have available to us, but bring it to that physical retail space? And so this is thinking much more beyond the traditional, like, patient to provider, face-to-face video telemedicine. It's very much, how do we have a health kiosk in a health hub so that someone can come in, and even without having a physical provider present, you can have, various vital signs taken. Maybe there is a video visit involved there, so you can see a primary care physician, you can see a pharmacist. I mean, I've even heard of these kiosks where they can do a diagnosis in the moment through telemedicine and then actually dispense any sort of prescription medication in the moment. So there's a lot that can be done in a retail setting that we wouldn't traditionally think of as a healthcare setting, but I think is increasingly going to be so. There's also a lot that you can do in the home. So when you think about a Best Buy or a Comcast, they are, deploying their geek squads. They have a services business where they can literally go into your home, not right now necessarily, but usually they can go into your home and help you set up your TV and your cable and all those things. Why wouldn't they also help seniors set up some sort of telemedicine device or a remote monitoring device or a smart chair or sensors or, something else that's going to help you in an ongoing way connect with your community, manage a chronic condition. And so I bring up these examples to kind of show the expansiveness of how we think about digital health. And that doesn't even begin to scratch the surface of tools that are created for providers. I mean, a lot of the challenge that we're going to have is dealing with provider burnout, figuring out how do we scale the work of these providers. And so telemedicine can even apply provider to provider, where maybe you have, again, a pharmacist or a primary care physician in a particular office, but then they're using telemedicine to connect with a specialist at a different facility. We just looked at a company that brings specialty care into long-term care facilities, into post-acute care facilities, so that folks don't have to leave that facility, which right now is a big threat to their health, but they can bring that specialty expertise in. So there's a lot of different avenues and exciting avenues to deploy this technology.
Those are great examples, Megan. I'll mention a specific one. One comment I'll make very quickly as you're talking about providers is this: the concept of providers is changing quite a bit, and what constituted provider 10 years back isn't so now. There are a lot of new phenotypes of providers, if you will, that are emerging, and technology is enabling that. I'll give you a very specific example. Walgreens just announced a partnership with Microsoft, I think about 3 or 4 weeks back, maybe 6 weeks back, that basically offered triaging of patients in their neighborhoods using Walgreens as a retail facility, but using AI, ML, other data solutions to basically create a care pathway for the patients. So patients come in, they get triaged to appropriate facility from there. So there's a bit of a disintermediation of providers that's gonna happen, and patients are gonna flow differently. And telehealth is going to play a significant role in that, in my opinion.
Right. I think that's really curious. Oh, Donald, you jump in. I was gonna.
Well, just speaking to Anurag's idea about how the idea of a provider has really changed over time. I think most of us now realize that we really have available to us really a team of providers, and they all have different specialties. So I think as people become more comfortable with telemedicine and they have the resources to do this, I think it will expand the conversation about someone's health. So you still may go in once a year to see your primary care provider, to have that check-in, to do something that's really in person, really check things out. But then you have the opportunity to talk with a nutritionist regularly, or a therapist, or a behavioral medicine specialist. And it doesn't require that you actually have to get back to that facility, but you've actually opened up a dialogue that is more continuous, and that's really more about your health and well-being, rather than just this periodic check-in to make sure that there's nothing really specifically wrong with you.
Okay, there's a question that I was going to ask, and somebody has already asked it in our chat group, which is, What about socioeconomic groups that do not have access to internet or technology? And that could get to the conversation, Anurag, about the rural removed locations.
Yeah, this is actually, thanks for that question. As part of Center for Global Health, we worry about this a lot. And often we think of technology as this panacea that solves all problems and creates, great outcomes at lower cost. And it does. But one thing that we don't realize is it does that for those who already have healthcare. There are parts of the U.S., rural U.S., for example, where there are no ICU beds, just as an example. And if you talk about Africa, parts of Asia, Latin America, that challenge gets even worse. Having said that, I think the concept of technology itself has been evolving, and smartphones, feature phones and smartphones access has increased quite a bit. So for example, in Africa, we have 80% of the households have some sort of a phone access through feature phone, and half of them are smartphones. So if we design our tele solutions in ways that address the most important needs of those communities, whether it's for example, one of my students is working on a kind of a app-based, I guess they're calling it testing, but it's not really testing, for COVID-19. So this is really based on the symptoms and what's going on in the neighborhood, if they've heard of anybody having had that disease. So households in rural parts of Africa could actually use that app to actually figure out whether they have COVID-19 disease, and should they go to a nearby health center to get themselves checked, and which could be about 50 kilometers or 100 kilometers from where they are. So you can use technology of the mobile kind, the mobile cell phone kind, to actually still bring care to them. But it's not a given that the technology is actually necessarily going to create that access unless we think about it. I'll give you another example. Eric Topol has this book that came out, I think, about a year and a half back, which talks about deep medicine and talks about how AI ML has the potential to make technology, make healthcare deep. A lot of healthcare that we do today, he argues, is shallow, and I agree with him. When we have only 5 minutes with our healthcare provider, doctor, there's not a whole lot we can do versus 20, 30 minutes of conversations that we used to have before. But I think one thing that may be missing from that framework is deep equity. Do we have the data coming out from those communities that allow us to develop algorithms and solutions that take into account the inequity in access to care in those communities, whether it's women, it's pediatric health, whether it's racial minority group care, African American women dying of postpartum hemorrhage, for example. I think there's a lot that we can do and we must do to enable health equity, and just having technology and it's going to serve everybody isn't going to really cut it, in my opinion.
Okay, we have two questions that relate to insurance coverage, validations, payments, and related to telemedicine. Do you see anything taking place right now? And it's not really your area of expertise, but do we see any movement in matching the need with the resource?
Yeah, I mean, Megan, do you want to take a crack at that? And I have an example that just came out yesterday in the newspaper, so I can share that. Go ahead, Megan.
Perfect. Yeah. I'll do this quickly, but I know one of our partners, for instance, is Blue Shield of California health plan, local health plan. They've started covering mental health visits remotely, which is something that they've only transitioned to recently. I think the question is, will things like that stick? I think it's hard once you give consumers that level of access and providers to roll that back. So my guess would be that a lot of these things are going to stick. You also see a lot of changes happening on the regulatory and reimbursement front for Medicare, increasingly reimbursing for telemedicine visits, but there are still constraints. I mean, I was chatting with a therapist who works in DC, and because of state licensure laws, she still can't see a patient that's kind of out of the district, out of state. So I think this is really creating a lot of focus and visibility on some of these access challenges. But Anurag, interested in hearing your example.
Yeah, so we've been tracking this quite a bit. I mean, as part of OWP's medical, this is a key factor in thinking about for health technology companies. Should they be partnering with telehealth solution providers, and should they create those solutions in-house? And unless there's a payment mechanism to pay for that, neither healthcare providers nor technology companies are going to really go deeply in that direction, other than Silicon Valley, of course, right? But over the last several weeks, we have seen a number of announcements that have at least partially or in some cases fully covered all televisits during COVID-19 crisis. And Tennessee Healthcare just announced day before yesterday, I think, that they're going to cover televisits permanently. Even after this crisis is over, this is going to be part of their coverage, which is remarkable. Combine that with a number of other health systems actually starting to think in those ways. I mean, from payers' perspective, honestly, I mean, it does create more, potentially lead to better outcomes at potentially lower cost, and this is potentially is the key phrase there, and we still have to kind of really deliver to that yet, but the promise is there, and I think I would my prediction is that a lot of health insurance players and CMS at some point will actually cover tele solutions, and it's not just your primary care visit or not just a regular follow-up. It could actually become more meaningful and deeper in the future. So I'm willing to bet on that, and my suspicion is in the next 2 to 3 years you're going to see a lot of move in that direction. Combining with that would be devices of the kind that Megan just talked about, where and I think Donald, you talked about it as well. You could potentially have these diagnostic systems or even intervention systems that could be in the clinic setting or home setting. For example, vacuum-assisted wound healing is an example of it. We already have solutions for that at home. If you could just think of that as connected health solution and IoT that goes on that device, and suddenly you have an intervention at home that costs the health systems less, but if there's a right coverage, the profitability may actually increase. So I think this could be a win-win for all the stakeholders, patients, providers, payers, society as a whole.
One thing I'll add is at the risk of beating a dead horse, this definitely does make us realize that we need to shift from a fee-for-service system to a value-based care system. Hospitals are struggling so much right now because they have these huge hospitals and facilities that they have to fill those beds. That's part of the business model. That's part of this volume-based business. When that volume drops precipitously, like it has, I mean, in some ways it's we're still seeing a lot of COVID patients, but you see a huge decline in elective procedures, which are the more profitable lines of business for these hospitals. It just shows you that, they can't make money in the ways that have made them sustainable if we're still largely functioning in this fee-for-service world. An example of this, one of our portfolio companies is Podometrics. They are for people that have severe diabetes and are at risk of diabetic foot ulcers. Their form factor, the technology is essentially it looks like a scale. You step on it every morning. It looks at the temperature of your feet, and it can tell from the temperature changes and the difference between the 2 feet if you're developing a kind of a foot ulcer, a diabetic foot ulcer. These are incredibly dangerous. They can result in a leg amputation. And so if you can get in front of that and let the care team know, it's just a huge win for the patient, for the healthcare system, because you're reducing the cost of that person's procedure ultimately. But that works, like that is right for the patient and the system in a value-based care environment. Because what you are doing is you are reducing downstream demand and downstream utilization of services. So we need to figure out how can we arrange our incentives in the system to invest in solutions like that keep people healthy, take care of them in the home, have more preventative measures, as opposed to relying on kind of what is now for the most part still a volume-based system. And I will say there's a lot of experimentation in areas like Medicare Advantage where you have these value-based systems. And so that's where you see a lot more creative solutions popping up around things like social determinants of health. How do we think about food and transportation and mental health care and all these elements that contribute to outcomes. We need, as a health system as a whole, to shift to more of that mindset.
So this is a bit of a stretch, but it's bringing me to the question about learning and training. And so there are requirements for not only the providers, but also the patients in being able to utilize some of these tools. Megan, you referenced the device manufacturers not being able to, be in the hospital to help with helping the doctors understand how to use the tools. But I'm thinking about the broadest human training requirement it's going to come to Donald and designers to figure out, how do we learn how to utilize all these tools and how to reframe all of our, what's the right word I want? I mean, just all of our interaction with. So if we're talking about training, Donald, how does it look in the design world to keep up with any of these shifts that are being made?
Are you referring to designers ourselves keeping up with what's happening and what these trends are?
Yeah.
Right. Most of what we learn is from our clients themselves. We have great clients who love what they do and love to share what they do, and will teach us anything that they can to help us create a better space for them. But, it was kind of a trigger for me when the idea of a medical device specialist actually being in an operating room, but maybe we will actually start to have more interaction with those manufacturers. Or maybe we will have more interaction with people like Megan so that we can understand really what's on the cutting edge of what's being developed. So we can start to think about what are the ramifications for space, how we create space, how we make space flexible to be able to shift, from day to day, from hour to hour, to be able to support all these different technologies. Yeah. So it creates opportunities for different kinds of partnerships than we had thought of before.
And then I have a sister who's a nurse practitioner, and her clinic, just in the midst of all of this, shifted billing systems. So they had to learn how to utilize a new billing system while they are trying to handle, it's a low income general clinic, but there are COVID patients coming in through a back door, and there are all of the standard chronic disease patients that are being dealt with. So the idea of keeping people up to date while the bus is rolling. I have a question about whether or not the device manufacturers or all the innovators are thinking about that and thinking about the training required, the learning required.
They are. I mean, this is actually, there's an initiative, a very large initiative that we are involved in that is helping one of the leading medtech companies think about what is their role. Traditionally, they have thought of, physicians and, healthcare systems, hospitals as their customers. Patients have always been their focus, but those patients have been more as beneficiaries. And the focus has been less on how they directly serve the patients. But increasingly, and not just in diabetes, but other therapy areas, it is becoming clearer to many of these health technology companies. And I say health technology because, they were called medtech, but health technology is a broader term, I think. They're starting to think about, do they need to actually engage patients in a more meaningful way? I'll give you an example. Stanford Healthcare CEO recently talked about how Stanford Healthcare is ready to receive patients. We are 70% back up in our elective capacity. Most of our healthcare workers have never been exposed, only 0.something%. Whether they're nurses, techs, doctors, and all of that was to message to patients and communities that we are ready for business, that we are safe, please come in. And that's become a very important part of this crisis. But even going forward, that direct communication between health systems and patients is going to probably increase. And I suspect medical technology companies or health technology companies will start to have to play a role in enabling that or supporting that. So let's say you have a brain modulation device, you are a Parkinson's patient, and you got a device on you, and you can't quite come in for titration of your device to the facility, to the hospital or the clinic. Hospitals may want to work with you, or doctor may want to work with you as a health technology company to engage these patients directly and sort of do that at home, and maybe train or educate the patient at home. Another example is hemodialysis, right? A lot of hemodialysis happens in these hemodialysis centers, but the future arc very much is about hemodialysis at home. And how do you then engage with those patients? So I think many of the companies that provide hemodialysis technologies will need to engage with the patient. So I suspect this will be, it already is part of their thinking, and they're wondering about how far do they go, but I think they're going to have to do more of that in the future.
One thing I'll add is I think all these players need to be really creative in addressing this challenge of like, how do you enable us to do these things in our home? So just to get into it, if you're thinking about creating diagnostics, like if it's a blood diagnostic, generally you're going to have to go into a lab to have someone draw your blood. If it's based on urine or saliva, those are things that are more easily collected at home by the patient. So like, are we going to see a shift there? Another challenge that I've thought of is, unfortunately, we're going to see a lot of people who are going to be in need of mental health care services. And when you're physically in the home, in the space, potentially with the people that are contributing to stress, or you just don't want people listening in on your conversation, like how do you outfit a room in somebody's home to kind of protect their confidentiality? I have a roommate right across from me most of the time. So these are like small examples, but I think it forces us to really be creative about how do we design a space where people are going to have at-home diagnostics, they're going to have more telemedicine visits, they're going to have some sort of monitoring, and we build provider practices and hospitals with privacy very much in mind. And I think we kind of assume that, the home is the most private place, but there's probably things that we need to do to ensure that is true.
Yeah, one thing I'll add very quickly to what Megan said about home diagnostics for certain kinds of things that the samples could be collected at home. And, we already do that with pregnancy tests. We do diagnostics at home, right? So it's remarkable that we haven't decided to do that for other diseases. And maybe RDTs for other conditions would get accelerated as a result of this crisis.
So we have a group of questions that are about the cost of all of these. We've addressed, what systems might be offering coverage, but there, our Chief Operating Officer, Mark Baker, had a question about with the economic carnage that many healthcare systems are currently facing, who will be making these necessary investments in the technologies? And so you, both Anurag and Megan, have experience as to who are the investors or the purchasers. You could speak to that.
Why don't you go first, and then I'll share my perspective.
Yeah, I'm going to start I'm not going to start with venture capital because we can talk about that, but I want to talk about like the biggest funder investor, which is our government. And before, with the question about, how do we deal with people who don't have access to these technologies, I've started to hear conversation and lobbying around how do we get Medicare and Medicaid to think about the underlying technology platform that one needs to access care remotely. So broadband service, tablets, making sure that, not just that the Medicare telemedicine visit is reimbursed, but that the people actually have the underlying tools to be able to take part in that visit. So I do think that healthcare is on everybody's mind. I think that some of this should be part of the public discourse in our upcoming election, particularly when you think about the large number of people that are unemployed and are going to they're not going to have their employer coverage anymore. They're going to be in the uninsured, underinsured, or Medicaid population. And we need to think about who is going to fund healthcare access for those populations. Historically, it has been the government. And I think that will, again, continue to be an important part of the conversation for the upcoming election, as well as just ongoing lobbying and advocacy efforts. From a venture capital perspective, it's tricky, right? It's a really tough fundraising environment right now. That said, the way that kind of we think about venture capital funds is that if they've already raised the fund, which many of them have over the past couple of years, they still have that capital to deploy, and they have to. So I don't think we're going to see like a huge dip in venture capital deployment of funds, at least for the next year or two. What you might see is like funds not raising as much for the next couple of years. But I think it's going to be tough. And I think a lot of those dollars are going to go, my guess would be, to later stage founders who have already figured out product market fit. And so the new investment is to scale what they're doing. That's really different than investing money in a really early stage founder who isn't battle tested. Maybe this is their first company. You don't know them. You're only meeting them on Zoom. You can't meet them for a coffee chat like you normally would. And so we gather data on this, so I'm excited to test this hypothesis for our H1 report. But I want to see, when you look at Series B, C, and later, is more capital going into those companies to help with their scaling growth, as opposed to going into these seed and Series A deals? Because I think that there could be an issue if we don't have some of that early stage innovation. That's where Rock Health sits. We do seed and Series A deals. We're still deploying capital, but I think if folks have the choice between kind of the bet on the early stage entrepreneur versus someone already in their portfolio that they know and trust, I think we may see more funding going into those later stage rounds.
Yeah, I think those are great examples of where potentially the money is going to come from. The way I think about it is, I think those folks are going to invest who stand to benefit the most from that investment. That's the way I think about it. So building upon what Megan said about the government, public investment, absolutely, 100%. I mean, there are so many people who are disenfranchised right now in terms of healthcare that it almost becomes a must-do for our federal government. But I would say there are now, especially during this crisis, there's been a lot of local decision making. Santa Clara, so Bay Area counties actually were the leaders in deciding on what we should do as a community in response to this crisis, right? So my suspicion is there's going to be a lot more, more localized use cases where resources may get allocated by local health systems, whether public health systems in particular. So that's just to add to that layer to Megan's comment there. But there are some other phenotypes of folks that will actually potentially invest in it as well. I believe that technology companies already are playing a significant role in resourcing development of technology solutions in the space. And they're not doing it alone. They're doing this in partnership with many of the health systems, many of the health technology companies, and so on. So I think there's going to be a recognition that investment in this area is important, especially if we shift towards value-based care versus volume-based care. I think everybody will realize that user technology is the only way you're really going to be able to get there. So my suspicion is that hospitals, health technology companies, pharmacies like pharmacy chains like Walgreens and CVS, and technology companies like Microsoft, Amazon, Apple, and Google that are going to invest a lot in this space, and they already are. I think there's enough evidence to suggest that it's already happening. So that's the other group where a lot of resources are going to come from.
Okay, I can bring this back to place to Donald for a second. Someone had a question about, let me just go back and see the shift in usage of space. Do you see that we talked about how pervasive telemedicine has already become? Do you see a shift in space usage at this point in time in your design work at all? In the types of spaces that are being designed, or the flexibility of space?
We certainly see a shift in the conversation, but it doesn't necessarily have to do with technology. It's a response to COVID. And I'm sure a lot of the healthcare designers right now are having the same kinds of conversations and maybe are going through the same kinds of questions. But it really has to do with how people collect together and how people physically associate with each other. So we talk about being able to kind of disperse away from the idea of waiting rooms. So how do you more efficiently bring people in and out of the building? If technology can be a part of that to assist that, to make the flow more efficient, I think that will be really, really key. I think you and I talked in the last few days. You had asked how technology had influenced the spaces that we'd worked on, say, in the last 5 years or so. And for us, it's not necessarily about the equipment. The technology is embedded in the equipment, and we kind of design around the equipment. But the technology of how you manage scheduling and flow has really affected how we design space and how they bring people in and out of the spaces. And now just knowing that you want to expose people to as few sources of contact as possible, that flow will be really important. You know, how do you make sure that you have the right number of exam rooms per physician or per provider, so that you're very efficiently keeping them utilized, but you're also able to keep them clean and safe. And you're also able to keep the patient or the client happy and reassure them as well that they're safe for being in this space.
A little bit of research that we're doing right now is on how should health systems, health plans be thinking about the digital front door to healthcare. A lot of us are starting to use symptom trackers or symptom triage tools. So there's a variety of apps that you can use to essentially say, hey, here's how I'm feeling, here are the different symptoms, and then it's going to then triage you to an appropriate next step of care. That might just be telling you that you're okay, and to check back in a few days to see if your symptoms worsen. It might be connecting you live with a physician who can help further triage your visit and figure out if there's something that they can provide you over that visit, or if you need to go somewhere in person. It sometimes includes being able to prescribe mail delivery drugs. So I think there are a lot of ways in which these organizations are thinking about how do we, like to use an overused term, but how do we reach patients where they are, which is on their phones, and make sure that there's a really seamless entry point into our services by way of providing them with something that's going to be really useful early on, which is like, hey, I'm not feeling well. I don't really want to go into the doctor right now, especially. So is there a way for me to easily check out what's going on?
Right. And there certainly is currently the ability to triage by phone, but that typically is to a person. And I think what you're talking about is being able to have technology and softwares that are actually managing this, and in a way can give you much, much more complex analysis and direction out of that, rather than just calling up a nurse who answers on the other end and you explain your symptoms to them.
Yep.
Yeah, just to add to that, a very specific example. It's from my family. One of my family members had a bad accident, and he's going through. He's recovered quite a bit, but he's going through rehab, and his health system actually connected him with Rehab Without Walls. So it was not so much about the space where he would have gone if he were getting his rehab in regular times, but in light of the current disease and the risks that it poses for the patients, they basically created a solution. Hospital system has created a solution where an outsourced partner is actually going into the home and doing this with the patients. So the space is getting extended, not just inside the hospital or inside the clinic, but also within the home. Home has become an extension of the healthcare system, basically.
Okay, we have 3 minutes left. So I'm going to give each of you one to wrap this up with your wish for the future of digital health and humanity. Let me put a big circle on that one. Anurag.
Well, I think health equity is, if I had to summarize it in one phrase, that is really what worries me the most, interests me the most, and I think that's where we've missed the mark for a long time. But COVID-19 has just brought that to fore in a significant way. There's a big part of humanity that we are not touching, that we are not serving, despite all of our abilities and all of our capabilities. So onus is all on all of us here on this call, but also the larger health systems, healthcare ecosystem, to find a way to use technology to help everybody, not just those that have healthcare access today. So that's my dream and wish.
Thanks. Megan?
Health equity is a really good one. I would also say that we remember to design for providers. I know to bookend, I think Anurag, you started with that phrase, but I think providers right now are making a Herculean effort to take care of our society, and there's going to be a lot on the back end in terms of, I mean, physically providers not being able to provide because they're infected. There's going to be a lot more burnout, I think mental health care issues, really understandably so. And so far, I mean, I don't necessarily think that physicians have a positive view of all the ways in which technology is supposed to help them, to put it lightly, like the EHR, for instance. So I really hope that we see scale unlocked because technology is designed for the use and delight of providers in a way that we haven't seen before.
And Donald?
Well, I'm excited about the idea of taking technology and taking it deeper into communities, with the idea of being able to set up tiny little clinics in senior centers and cultural centers, and maybe the public school on a Saturday when there are no kids there. But it's difficult with the way our system works, where we have such a complex network of providers that are all competing against each other. And I think the opportunity would be much better under a single payer system, or a system that was closer to that. So I could see in another country where healthcare is really part of the government benefit, that you would probably see something like this happening. I think there was a push, maybe 10 years ago, where people started, where providers started talking about opening up small clinics in shopping centers and strip malls. And I just think the reality of that is that you haven't really seen that happen, because it's so expensive to build out a little clinic and there's just no economy of scale. So I think that's the challenge of how do we work within this complex provider network to be able to really distribute through technology into the communities.
Thank you very much, each of you, Anurag, Megan, and Donald, for contributing to this really rich conversation. And seriously, the amount of questions that we all have have just been touched the tip of, and so we can continue this dialogue in the future. I would like to thank our healthcare team at One Workplace for collecting you all and allowing us to have this conversation. And I would also like to mention, we have upcoming, I believe tomorrow, there is a Steelcase session, May 28th, on virtual care. Is that the new normal? So it's a continuation of the conversation. And then for all the rest of our One Workplace folks, upcoming at the end of May, we have our Wonder Grant research results being held in a webinar as opposed to an online or an in-person celebration because of the situation. So the first conversation with HPS is on May 27th, and they did an enormous amount of research about sustainability for interiors and what that might look like moving forward. So please feel free to join us. We thank you all for spending time with us, and have a great day.
Thanks so much.
Thank you.
Thank you so much for having us.
Okay, bye-bye.
Bye.